Is familiar with the Snowman City? No. Just for a quick introduction, so it's a medical terminology, so it contains all medical terms. So it's originally come from SNOMED and city. So SNOMED was from US and city for clinical terms from the UK. Then they combine all the terms into this SNOMED City. So it contains more than 300,000 plus concepts, which is all these medical terms for, let's say, acute coronary syndrome and etc. Angina, whatever. Okay. So this here, what we want to do, we want to harmonize our data using this standard, this terminology. So here, this system. So this is for demo purpose here. So we have three functionality. We can upload data in the system, codify the data, and then query the data and see what's the value of having a SNOMED city codified data. So here I will just go through. So I will show you the example of patient diagnosis we received from hospital Azlan. So this the patient ID and date have been anonymized, but the diagnoses are real diagnoses written by doctors. So here you can see we have four variables: ID, patient ID, diagnosis, and date. And the first record is 14201, and the diagnosis is infective diarrhea with underlying right heart failure, fast atrial fibrillation secondary to infective diarrhea, and comes to a certain date. So here, each record is one encounter with a certain diagnosis written by the doctor. Okay. So here, we just want to bring this data in the system here. So I just get the data here in my system. So here you can see the data is in. And here for this demo here, we have 67 records. So what I want to do here, the step is to codify this data using SNOMED City first, later and query the codified data. So here I just go on to codify the data. So here it's a bit, the resolution is a bit. About 1 second. So here you can see on the right hand side, this is the data that we had previously, but now it has been codified with the SNOMED City. So here you can see, for example, the right here has been codified and assigned this code 2402807, which in SNOMED City means the laterality right. So here the system can detect, can be the laterality right, will be right or wrong, or etc. You can have different possibilities. Here we have heart failure, it's a certain code. AF for atrial fibrillation is a certain code, and etc. for all the rest. So here for this, at this moment, we are using a cardiology subset of SNOMED City that has been built with MIMOS and MOH with end cardiologists. All right, so I just move on. Now we just want to show you the query part. So here on the left-hand side, I want to query the normal data, the raw data, and then later I will query the codified data. So here are a number of cases of ischemic heart disease per year. So this is my query here. So I just query this data here, and as you can see, so here you can see, here's a graph on the bottom here. In 2011, I have one case I found. In 2012, one case, and in 2013, one case. So the system found 3 cases for my query here. And here, if we see the data here, it will be highlighted in blue, the IHD for ischemic heart disease. So we have one highlight here, another highlight here, and a third highlight on ischemic heart disease. Now, if we send the same query to the SNOMED City codified data, so we have to query this number of cases of ischemic heart disease per year, these are the results that we obtained. So I try to do it there. All right. So here you can see, in 2011 now I find 13 cases, 2012 40 cases, and 2013 11 cases. So here my reporting is much more consistent after I have harmonized this data. And here, if we go back and we look at the data, what we capture here, so we can see that, for example, we capture acute coronary syndrome to be some sort of ischemic heart disease. So we are able to deduce that, unstable angina as well, and for sure IHD for ischemic heart disease, and STEMI, and etc. So here from this data here, we get much more consistent reporting compared to the raw data with the harmonized data which has been standardized using SNOMED City standard. So this is the main point of this presentation. Thank you. Sorry for the disagreement.
and that is very limited terms that we have. And it's the point to remember is every step of the way we have to verify with the domain. We have a group of cardiologists working with us. And finally, Dr. Omar, who is the head of cardiologists of Malaysia, will have to endorse all the work that we have done. Yeah. This is a story about what is nomicity, which I think you are very familiar with, and I don't need to elaborate. And this is the relationships, and we have to work with more than 300,000 concepts and relationships. And this. We can do this manually, but not this too, because part of thing that we need to do is to enrich cardiology concepts, and the team from Halipomatic Center went through this and pick and choose the terms that should be included in the cardiology reset, and later verify with the cardiology teams, and we did that. Why we did that? We have to do that. So this is an example of the relationships in the term that we have chosen, and we have to be very careful with that. It's not a simple database you can just extract. When you do a query, you must understand I think the system or the MyHarmony must understand the semantic of that nomicity, handling the relationships. This is showing you the symptoms, the logical formula and whatnot, and this is the tools that we use for that purpose. I think this has been properly demonstrated. I don't need to repeat that. This is one of the first slides that we developed when we tried to develop MyHarmony, trying to justify what we are trying to do. And this is what we are getting with MyHarmony, with all the different terms. But if it carries the same meaning, instead of 1, you get 3. Yeah. So if you look at breathlessness, sesak nafas in Malay, and then this here, they're all the same terms. So with nomicity, you are able to codify, they are the same thing. And then when you search or query, you get the 3 things together. And that was the intention when we first started, and we managed that with MyHarmony now that we are planning to roll out. Sorry, that was the plan year ago. I'm happy because we are seeing something coming out of MyHarmony. The work that we have done includes this, a copy of the database from our HS hospital, and we need to do some reverse engineering to get this legal, but we did that. And then we need to formalize methodology for the development of website. We did that, and we presented to ICSEO just to make sure that we are doing it right. And then the team from MIMOS developed this tool, which is MyHarmony. And now we have the database, we want to codify them, but we want to improve on the website because that was limited to the term used in the registry. But now we want to include every term, every possible cardiology term, so that when you codify and when you query, you get all the cardiology. Hopefully by August we can roll it out and you can start using them. And it is very important that in the whole process, whatever you do with MyHarmony, you ask the people to do it manually, and then the finding must be the same. So every step of the way we verify, we validate that the technology is working for us. To us, it is a crime because you provide data, and from that data, people make decisions. Yeah. And these were the findings, and we presented this in ISTSGO to get some international feedback and whatnot. This is some of the use. I think after the demo, you may know what to do with that. Moving forward for us, what we'd like to show you is, this is where we were in November 2015. Cardiology website, this is based on the registry. We have only 580 terms. And then we have this project. And we have this ongoing development and testing of My Harmony Platform 1.0. And then we have extraction of cardiology terms in Snowman City. From 300,000, we managed to extract this amount. This is done by the medical doctors. And then the finding here is verified by the cardiologists, a team of them, headed by Dr. Tomo. And we use these to upload into My Harmony so that we enrich them. It's not really a clever system, but we're building on the knowledge on the terms. Yeah. So hopefully we can do UAT sometime in June and roll out sometime in July. But this is a silo system, and the next step is to integrate that with the Malaysian Health House. So that is the plan. This is the methodology. We documented them. And this is also important to remember because we have synonyms and also acronyms. Different usage of English. I did give you an example, rapid and fast atrial fibrillation. And then they have AF for something else, atrial flutter also. So cardiologists will have to help us on the development. Yeah. So this is to demonstrate to you when we first search fast atrial fibrillation, it doesn't come out because it is rapid. For example, this is the intention. Finally, everything is integrated into Malaysian Health House. And these are the list of applications that we would like to see fit into our Malaysian Health House. And if we have the database that we can codify with Snowman City, we would like to have that too. So in the end, you'll have a database that is coming from the HIS hospital, and also you have a database that is codified with Snowman City, and we demonstrate to you the benefit of having these codified in that Snowman City. And finally, when everything is integrated, My Health Data Warehouse will be able to generate information based on the normal database and also compare with the Snowman City database. That is the journey and the target. Thank you very much.
Thank you very much, Dr. Khadzir. In the interest of time, we will hold questions to the afternoon. Okay, we will move on to the next speaker. The next speaker represents the Social Security Organization, SOCSO. And the talk will be delivered by Dr. Azlan Darus. Dr. Azlan is the manager and for prevention and health promotion unit and the medical and rehabilitation section of SOCSO. Dato Muhammad Ahmad, the CEO, is not able to attend, and Dr. Azlan has very kindly agreed to represent him and to represent you. So please welcome Dr. Azlan.
Thank you, Professor Thomas. Thank you, everyone. I hope you are still with us today. Lunch is just about to happen in about 1 hour. Okay. Ladies and gentlemen, my name is Azlan. I'm a manager for prevention and health promotion. First and foremost, I have to apologize and send highest regards for my CEO, Dr. Ahmad, who has actually agreed to come over and talk, give this talk today, at least until last Friday. Called me over the weekend, said he can't make it. He is now outstation, so I asked me to send this paper today. Now, I hope, I'm not sure whether you're all familiar with Social Security Organization. Therefore, I will have 2 slides to just introduce everyone what SOCSO is all about. We are a social security fund made legal by the enactment of the Employer Social Security Act 1969. Therefore, all employees in the country who work with the private sector who earns less than 3,000 ringgit per month are actually compulsory to be contributed to our SOCSO scheme or Social Security scheme. And together with a few other agencies in the country, we provide the Social Security coverage for all Malaysians, including, for example, medical benefits. Of course, we are a very small player compared to the Ministry of Health, but we are the only one who provides employment injury benefit and also invalidity benefit as well as survivor's benefit. I'll talk to you about what all these benefits is all about a bit later. And at the moment, we are currently insuring about 15.5 million workers, and including about 900, almost 1 million employers in the country. So possibly half of you, if you're not from the government who sits in this room today, you are all insured by us, and your contribution are paid for by your employer. And of course, we also manage about 100,000 new claims every year, and out of these new claims, we manage about 63 or more than 60,000 claims for accidents, occupational accidents, including commuting accidents. We also manage about 18,000 new claims for invalidity. I'll tell you what invalidity is about, and also about 12,000 claims for survivor's pension. So this is the vast number of information or data, if you like to call it data, that comes to us in Social Security Organization. And when I'm not talking about the contribution part, I'm not talking about the employer, I'm just talking about the claims, and all these claims are coming from injury as well as disease, which we are today here talking about how big data and how our perspective in SOCSO is regarding data and healthcare. So what is big data analytics? Actually, it's not a question that I'm here to teach you all. It's a question that I'm asking you all to come and teach me. But from what we've read, okay, this is a very, it's electronic health data, so large and complex that it's difficult or impossible to manage with current software, and it's also impossible to manage with traditional common data management. About a couple of months back, there's an IBM representative here, yes? So we have an IBM representative came over to SOCSO and teaches SPSS, a new version of SPSS. And we thought that was very complex. Until towards the end of the presentation, he showed also what you guys have for the big data. And we are totally lost by that time. But thinking about it again, and also by preparing this presentation, there are a few things that we wanted to do which probably can only be done with big data analytics. And looking at what we do or what we provide in terms of healthcare, there are a few areas that we'd like to see. We'd like to collaborate with some people in here as well to see what we can do to get this done. Okay. So in SOCSO, these are some of the areas that we looked at: benefits and operations, research and development, evidence-based determination, and also in public health. I'll start with the first one, benefits and operations. Now, ladies and gentlemen, we process about 60,000 claims every year, and out of this claim, 35,000 claims are industrial accidents, 28,000 claims, more than 28,000 claims come from commuting accidents. Now, commuting accidents are accidents that occur when they are driving to work or going back home after work. Also, when they are driving to such a conference like this, under the order by their employer. Okay. So all those are commuting accidents. Now, with this kind of accidents, there are a few benefits that we give. One is a temporary disablement benefit. These are the medical leaves. So the moment a person is injured, they get medical leaves paid for by us. And if the injury becomes permanent, then they get a permanent disablement benefit. Now the numbers at the end are just the numbers of injured persons. This is 2015 number. Dependence benefit, about 40,000 insured persons we have to process. Now, how soon or how fast can we go and help these people? This is the question that we wanted to see. Recently, we tried something really new in our operations anyway, where we tried to link up police data. So whenever a person had a road crash and suffered from a road crash, we do not want to wait for them to come and apply for the benefit. We wanted the police to give us real-time data so that we can go to their house and say, look, you have suffered this and this is the compensation that you will get. And more importantly, many of these are actually road deaths. So road deaths, regardless of what the cause of the accident, whether it's commuting or whether it's not commuting accident, road deaths, they are eligible for compensation by SOCSO. And we wanted to be there during the first few days, the moment that we know about it. Of course, there are some grace period that we have to wait so that we don't upset them as well. Some people say, death is not a lottery, so you don't come here and start give us money. So this is some of the things that we wanted to see. How whether can we do it fast? How fast can we do it? The next two benefits are the ones that is given from due to invalidity. Invalidity means you are not able to work anymore due to any reasons. Okay, we like to call it medical boards, right? In our usual practice, in SOCSO we call it invalidity. And sometimes a person who not only they are not able to work, unfortunately they die while they are still in working age, and therefore we shall provide a lifelong survivor's pension to the spouse. And if a person becomes invalid, then this person will get a lifelong invalidity pension. Now, how can we process this faster? We need more information. We need a lot of information coming from a lot of people. We need to know how, we need to be able to integrate the medical report. We need to be able to integrate the, just to know whether the person is still working or not. We need to know when this person becomes morbid and he can't work anymore. All this information, although we can get it from the person, it's much faster if we can integrate data from other sources. But more importantly, we also wanted to predict who gets invalid, who becomes invalid, who becomes unable to work, which work area, what age, what are the risk factors. So these are some of the information that we have. We have the geographic area, we have the diagnosis why they become invalid. We have the monthly contributions that they have. We know where they work. We know what industry they come from. All this, of course, doesn't come in structured data. That's what Dr. Khadzir said this now. Probably semi-structured, more like it. And we also have some other issues with all those benefit as well. Some of the injuries, they have become better. They are able to work anymore, and we wanted to know, be able to predict when can we start to follow them up, or when we start to actually see them to make sure that we don't overpay or we don't underpay as well. So these are the areas that we looked at. And the other thing is we also have a rehabilitation benefit. Rehabilitation benefit means that everybody who actually had an injury, occupational injury, we will provide rehabilitation benefit to them. This includes wheelchairs, walking aids, if the person had a stroke and all the facilities, the home care, these are all provided. And also, we provide rehabilitation so that they can return back to work as soon as possible. There are a lot of information missing from this rehabilitation processes. We have our own data to look at where, how, where, who these persons are, but a lot of other information we need to look at, the types of facilities that we have in a lot of other places. We have a mantra to say that the person is not disabled, but the society is making them disabled. So which area will enable a person to come back to work? We don't know. Maybe the local offices, local office can help us, or maybe the city council can tell us. And we want also to look at again the speed of providence. How fast can we go and help these people? How soon after injury actually a person can be back to be rehabilitated? Do you know if you broke your, do you know if somebody broke their leg, how long are they supposed to be on MC for? If you look at different hospitals, different orthopedic surgeons, different clinicians, different area, you get different length of medical leaves. And if they start to shop for doctor, even better. A pinky fracture will get 250 days medical leave. Right? So these are the things that we need to learn and look at again so that we can go in and say, look, it's time, it's already up, we need to be able to start rehabilitation. At the moment, we arbitrarily put 180 days for all cases based on our experience, but we don't know what is the real practice happening out there. So these are some of the things that we open up and say, look, a lot of data sources, we want to look at the benefits and operations, improve the benefits and operations. Now, the second area that we look at is research and development. We are traditionally known to be a body for compensation. If you get injured, you pay. But we are also embarking over the last 10 years into prevention because we have increasing number of occupational accidents, we have increasing number of occupational diseases, we have increasing number of benefits that we pay out every year. Last year we reached almost about 3.2 billion ringgit Malaysia in compensation. So we are also looking into prevention, and some of the prevention work that we do includes research and also development of programs or plans based on those research. Now, one of the areas that we are very interested in is actually commuting accidents, because at the moment we are the only organization that look into commuting accidents apart from the Ministry of Finance, who look at the ex gratia system for the government offices. And we try to profile accidents, we try to profile the commuting accidents. Who gets accidents? Motorcyclists, yes, they like to weave through traffic, yes, they like to speed through above the speed limit, yes. But there's still many more information that we like to look at and maybe even share with us. Where are they geographically when this happened? What about the environment? Rainy days, sunny days, what about the roads? Potholes, no potholes? What about the type of motorcycles? Or the type of cars? So this information, there are a lot of data that we need to be shared, and it can't be managed by doing a ad hoc research like what we did, which I'm going to show you this a little bit. So, and this information determines the types of preventive activities and also determine the target medium. And more importantly, is also to help us to look at the impact and the reach of our prevention program. This is what we do in prevention. We have basically put it up into 5 categories. We look at national policy, so we're involved in the occupational safety and health plan for 5-year plan, so now we're going to 2016 to 2020. We are also into networking, we are looking at awareness and education. There's some audits and guidelines and research and development grants even. So a lot of our activities that we do, for example, with networking organization to pamper or to try and guide companies to help them into the making workplaces more safer. We have the data set for all these activities. We have how many people are trained. We know what happened to their occupational accident rates after the training. But that's not enough for us to plan further, because we're not sure how bad or how much further can we go. Awareness campaign is the same thing. This is Abington. This is what we planned for a long time. So we produce videos, we produce posters and pamphlets. Some of our videos are, we're proud to say, quite good. We won an international media festival. And then after the videos, we thought, okay, we need to go ahead and do something else. So we think about social media. We put up the videos into social media, and also we produced the first ever occupational safety and health series on TV. And last year, we were told it was watched by 10 million people, but really we don't know what's the impact. Like the earlier presentation, very interesting, we showed when we banned smoking, how many people has reduced the hospitalization for cardiac events. Actually, we're not even able to say that we get less. It's difficult for us to say that we get less occupational safety or occupational accidents because of our effort. So these are the type of information that we probably can get from other agencies as well. And research grants. Okay, so these are the ad hoc research grants that we put up. But that's not enough. That's why I think it's important for us to be here today and see what's happening in this big data and see how people are also collaborating. It's very interesting to see what's happening in Scotland, and also quite pleased to listen to what's happening with the Ministry of Health, because soon I'll talk about health as well. The next part is, this one's even, it's interesting for me. Now, ladies and gentlemen, part of what we do in compensating for occupational accidents, impairment rating. Now, if a person lost an arm, how much of that person has been lost? You put it in number, 10%, 15%. Make it lost a whole of right arm, which is a dominant arm of that person. Can you guess how many percent the person has lost? 20%? 60%? 100%? No, right? Okay. Less? In our method now, the person has lost 60% of his ability to do activities of daily living. Now, the question is, where do we get 60%? Why is it not 40% or 30%? It is 60% because we have adopted the American Medical Association guideline on impairment rating based on the conditions of what they have in America. To do our own Malaysian, how many percent we've lost for every single impairment that a person has. Now, losing one arm is easy to count, okay? But what happens if you had a fracture and the elbow is ankylosed at 30 degrees, for example? So how many percent is that? So to do that, to do this guideline, or to find out how much a person has lost, need a lot of information shared between a lot of agencies. Because this is not about functional loss, this is about a person's ability to do his or normal activities of daily living. So how much can a person do? So it depends on a lot of information, not just the injury. So yes, that's the blue book is our guideline. What about invalidity? Now, a person is injured or have a disease. Let's say he has a cardiovascular disease, has a heart failure, ejection fraction of 45%. Can he still work? We have to decide, because we're going to give him or her a lifetime pension. Or a person lost his foot at the level of the ankle, can he still work? You will say it depends on the job, right? Okay, so if he's a lecturer, he can still come up here and give a lecture. But if he's a lorry driver, quite difficult to press the accelerator and the clutch. So can this person work? Can this person work? Now it's a very difficult question. To enable us to answer that question, we need to have information on the level of loss, the impairment rating that the person has, and the activities at work, and the education level or education, education level that enable him to do other work, so that then we can determine that this person can or cannot work anymore. Do we have a guide? Yes, we have a guide. The other book. Here, this is our guideline, and this is arbitrary, not based on any research. It's based on expert opinion to help us to become objective. How can we do this guide? Big data. So this is our evidence-based impairment determination. Finally, the last one, public health. Now, we all know we have a high burden of non-communicable diseases in Malaysia, but do we know what is the impact to the workers, to the nation, and of course for us to the Social Security Fund? So we look at some of the studies that other people have done. This is done by the Australian Victoria University, and say, look, Malaysians are aging. Yes, we know Malaysians are aging, and we also know that Malaysia is having this problem, that problem. And this is from our health screening data. We have managed to screen about 450,000 employees in the country, kept all their health records, and this is what we found. 72% of all our workers, engine of the country, are either overweight or obese. About 9% has got diabetes, 47% got hypertension, 62% has got high cholesterol level. If you go back to the premium study, then you can see the premium scoring 10%, 10-year possibility of getting cardiovascular disease is also very high. So this is what's happening in Malaysia. What's happening to our fund? This is our invalidity pension. Invalidity pension, again, the person can't work anymore, and over the past few years, it's keep on increasing. Invalidity pension due to non-communicable disease. Now it goes up to about 50% of the total invalidity pension that we have. So how many of them? I'll show you later. Now, the other one is survivor's pension. Workers who died before the age of 60 due to non-communicable disease, heart disease, stroke, cancers. Again, it is now about 50% of the total. If we look at non-communicable disease, last 2014, sorry, not 2015, 2014, we are seeing about 13,000, we have approved about 13,000 cases for the whole year, which comes to about 40 cases a day. We are losing Malaysian workers through non-communicable disease. They either die or they can't work anymore. So how much more can we do? How much more can we lose? This is also done by the Victoria University, looking at the cost of non-communicable disease, and say in 2015 we're losing about $16.3 billion, or about 4.7% of the GDP. Or if it keeps on continuing and we don't do anything, we'll lose about 6.3% of our GDP due to NCD alone. If this is not enough motivation for us to come together and look at the data so that we can plan for non-communicable disease better, then can't be any other bigger motivation than this. 3 years ago, we started the SOCSO health screening program. We managed to screen until the end of December about 440,000, now it's about 460,000 employees all over the country, and about 150,000 women has gone through mammogram as well. We need better strategy to get more people to start taking care of their health. One of it, yes, of course, they do a health screening, but all the other aspects of active lifestyle and healthy lifestyle as well. 446,000, quite big number, which we hold their health data, but there are still 1.7 million workers out there who are eligible who have not used this opportunity. We need to be able to gather more information so that we can try and tackle, get people to start thinking about their health as well. So, trend of use, for example, based on employers, based on country, we have health-seeking behavior. Well, 63% of them actually have not had any health screening before. But the answer that we're looking at is why. Why are they not coming? Why are they not using this health screening? Is it because difficult to come? Is it because the area? Is it because the age? Is it because they have done the health screening before in Ministry of Health? We don't know. But if we don't do, this is our prediction. It's simple prediction without any complex data analysis. It's a linear prediction. In 2020, we might go up until 76 a day for our invalidity and also survivor's pension due to non-communicable disease. So there's a lot of challenge doing this or trying to do this. That's why we are glad we are here so that we can learn from you. Capacity building. I'm not sure if they are experts in big data in our organization. Maybe they are in dealing with huge data, but I'm not sure with big data. I'm not sure how many experts we have in the country as well. But now we have been approached by one or two universities to say, let's look at big data. And availability of tools. There are many tools in big data, I believe, which we are not familiar with and we don't know what they are able to do. What's been shown just now, the SOCSO is fantastic because it's really something that can help us as well. Our second challenge, digitization. Data sets, most of our data sets actually are in databases, except that we have so many databases. We have different databases for contribution, we have different database for rehabilitation, different database for disease, and also different database for the health screening. So that's another challenge. And finally, of course, the policy is very important. We need to be able to determine what is required, something that we'll learn, but when it's required, and also the agreement, the governance part is also very important, so that we can agree with others to share and to be able to do it. Ladies and gentlemen, this is my last slide. So big data, health statistics, SOCSO, yes, we have complex data, we have a lot of data, we have different type of data, and we get data that comes in fast, for example, the accident data, and huge data as well. But our biggest challenge is the veracity of the data, whether the data can be used or it will be within the same type of data before Ministry of Health put it into this complexity. So thank you very much for your time.
Thank you, Dr. Azlan. Ladies and gentlemen, we've had the first speaker, Professor Andrew Morris, show us information about Scotland and how the system that works may not be perfect, but something that we can work towards in our country. And we had Dr. Khadzir talk about Ministry of Health and their initiative towards using big data. And then we have Dr. Azlan telling us about information from workers that is available. And again, the point that was brought up is how we need to work together and share data. In your bags, there is a feedback form. And one of the questions in that feedback form is that if you are an owner of a data set, are you willing to share that data? Okay, so I hope you will take some time to fill up the form before you leave today. It's not time to leave yet, but just letting you know early so that there is a question that you can just tick a box whether you're willing to share the data. So the next, we have heard from Ministry of Health, from SOCSO. The next user of big data is the insurance industry. And we are very pleased to have Mr. Kiat. Mr. Ho is the Senior Vice President and National Practice Leader, Employee Health and Benefits for Marsh Insurance Brokers, Malaysia, Sdn Bhd. He is currently the national leader focusing on the growth and expansion of the employee health and benefits in Malaysia, responsible for the strategic direction of broking, healthcare, flexible benefits and total wellness solution. Mr. Ho has more than 7 years of experience in the mutual fund industry and 10 years in employee benefits. He and his team of PhD specialists have helped companies in Malaysia transform workplace strategies using choice-based benefits and wellness solutions to maintain costs and improve employee engagement. Mr. Ho is a frequent speaker in various human resource and employee health and benefits events. He has spoken on a number of different subjects related to health and benefits. Please welcome Mr. Ho.
Everyone, while they're setting up the deck, I'd rather not waste your time because I'm standing between you and the lunch. So they call this the graveyard shift, where your minds are obviously at the cafeteria. But let me remind you, today's a healthcare talk, so before you sink your teeth into carbs and saturated fats, let's go through some of the information. I don't know whether this sounds interesting to you because I think my presentation today is positioned more from insurance companies and companies involved in healthcare. So you're looking from a perspective of payers to private healthcare. And this is more very different from what you've been hearing to this one, which I've read a lot of content. But what my presentation is from the perspective of business and commercial. So I hope it sounds interesting. If it's not, then please don't skip. I've been underwriting for an insurance company for more than 9 years. Then I move on to consulting for Mercer and Marsh is a consulting plus broking business. So what we do is we engage clients to manage their healthcare costs. And while we do that, we also do broking for their healthcare as well. So before I start, I just want to know how many of you are students in this room? Just raise your hands, students. Right, so most of you are working here. So in the Malaysian context, about 90% of companies provide healthcare to their employees. 90%. When we talk about healthcare, it's outpatient and inpatient. And out of the 90%, most of the companies, prevalence is about 70% of companies transfer that risk out to an insurance company. So that is where we talk about healthcare costs. Because both the insurance company plus the companies themselves have a lot of vested interest to manage healthcare costs. And so the talk today is talking about how companies and insurance companies are facing challenges with healthcare. What do they look at? I'm going to start talking about what were the data that we're looking at in the 1990s when I was an underwriter with an insurance company, to now when I was a consultant with a firm. What sort of information do businesses look at when they look at healthcare costs? What do they do? How do they manage costs? How do they benefit design certain of these benefits for the employees to make sure that there are a lot more consumerism in the benefits as we see today. And I think it's evolving. I think what we have shared today, we hear very much from the speakers this morning. It is very interesting. A lot of, we know that it's from the academic side of things, but we also look from the business side of things. A lot of organizations, insurance companies are looking at pushing everything together to make some meaning of it, to some answer why and how, where, who, and how do we manage on this. So that's a lot covered in there. To insurance and companies. On the top side, we look at insurance companies, and the other side, insurance and companies. and looking at why they collect information on a very submissive purpose, when you look at things, how is the benefit or the cost progressing. On the other side is quantitative, where you look at collecting information to improve the condition, and look at the different sets of data that's being collected by the insurance company and insurers and also companies. And we know that one of the highest payers in healthcare, we think, are insurers, but they are also organizations. Most organizations insure only the inpatient, which is hospitalization, to the insurance company, whereas the outpatient, which forms a very large component of the cost, remains self-insured. And who is paying for it? Organizations. So in the past, this is where companies are looking at a very way to just manage the process. However, you notice that medical inflation is on the surge. How many of you know what medical inflation is? How many of you know how much is medical inflation in Malaysia? How many of you know the GDP or inflation rate in Malaysia is about? Depending on which level was, right? So if you look at the safest of Bank Negara, it's about 3.5%. But 3.5% is the GDP, that's the inflation. But what is the medical inflation? How many of you think it's below 10%? How many of you think it's above 10%? How many of you will not hands up whatever question I can ask? Obviously, wanting to eat, right? So, medical inflation is where we send out a survey to insurance companies on an annual basis to the top 10 medical providers in Malaysia to check what is the medical inflation. Last year is about 13.5%. This year it's 16%. Singapore medical inflation is below 10%. So if you look at the very developed nations like Singapore, Hong Kong, Korea, Taiwan, the medical inflations are not controlled. It's easy about double of the inflation rate. Whereas you look at countries like Thailand, Malaysia, Indonesia, we're usually about 4 to 5 times inflation. Medical inflation is going 4 to 5 times. So what is ailing the nation? It's also ailing the companies, right? Because cost is increasing. Imagine if I hire you as an employee, I pay you salary, and every year salary increases by COLA 4 or 5%, right? But if I also give you benefits, if every year your benefit cost increases 15 to 16%, Mr. CFO and Mr. CEO will be very concerned, right? Because your cost is increasing. That's why I have a job, because they came to us and asked us, how do we manage this? How do we manage costs with this while engaging employees, while looking at benefits, while looking at getting a good deal from the insurance company? So that's where everything starts. Next slide. I can't control this sound. So this is where, if you look at the last 10 to 15 years, this is the information which all of us look at, called a loss ratio. If we insure a program to an insurance company, an actuary or an underwriter like us look at what is your claims. Total claim 100 over 1,000, total premium 125,000. You take this, divide by this, you get loss ratio. 81% loss ratio tells you that every 1 ringgit I pay the insurance company pay 81 cents of claims. The other remaining, the insurance company will pocket as their profits, right? So this is just a very broad or very easy way to manage medical claims those days. No big data, no analytics, it's just no rocket science, right? Yeah. But along the way, you notice loss ratios keep increasing. Along the way, since I joined the insurance industry and medical insurance, we have more than 6 insurance companies that have given out medical. So 2 risk insurance companies don't like seeing. First, motor. Second, medical. Because these risks are things they cannot control and they start losing money. Then, next slide. Companies and insurance companies start to make sense. Who contributes to these claims? How do we control these claims? So then the WWWH comes in. Where is this claims coming from? Is it coming from operators, executive, senior management, the CEOs, and like what was alluded this morning, comorbidity claims, those who have more than one diagnosis, usually comes from, when we look at most of our clients, the lower level, the operators. So now we know where our claims coming from. Where does claim come from? Each plant. We have so many manufacturing companies in Malaysia. For example, we spoke about dandy this morning. We have a client who has got very high dandy claims. And when we look into the data, most of the dandy claims come from the night shift. It means operators who have to work in your factories in 11 o'clock in the morning, 11 o'clock in the night, and finish at 6 o'clock in the morning. While the shift, during the shift, right, they have to wait outside for the buses. So that's when they got the dengue. So again, analytics help insurance company, help clients to start looking at changing the process to prevent claims. So where does claim come from is very important. When do they claim also is an important factor. You know, we are full of, Malaysia is about a multiracial country, right? When do claims happen? Most of the claims happen if you're insured an optical vision, November, December, right? That's when year end, you're running out, you know that if you don't finish your limits, it's going to be forfeited. Vision, optical claims finish fastest at the end. But hospitalization claims during Ramadan month, those fasting period, or the certain race, the Chinese Ghost Hungry Festival months, we saw a decline in hospitalization claims. If you were an underwriter, you start underwriting these claims, you need to start look at all these factors into pricing your policy. So again, data analytics has moved to a different level. Look at utilization, look at where the claims come from. What were the claims? What are these diagnoses? What are the top diagnoses that organizations are facing? Is it diseases that we control? Is it chronic diseases, non-chronic diseases? Is these diseases that we can prevent, that we can control? Who incurred these claims? Now, most organizations cover not only their employees, they cover their dependents. And in urban areas like Kuala Lumpur, both husband and wife usually works. So one thing the organizations has never understand, or insurance companies never understand, why do 30% of the claims come from dependents, where both husband and wife works? Shouldn't be claimed from your employer? Why do we still need to extend coverage for dependents? So when we work with some of the companies out on the northern side, when we start changing the plans for dependent, for example, we tell the employee, we cover you in full, no problem. But when your dependents start claiming, that's a 10% co-payment. Guess what? You will notice the claims of that company has flushed up to the other companies. Especially we see this very much in the Penang Free Trade Zone. If you've been to Penang Free Trade Zone, you see all your multinational high-tech manufacturing companies, your Dells, your Robert Bosch, your Intels, Motorola is all there. One company start changing benefits, you will see a ripple effect. Because of this, who is claiming? If you look at East Coast of Malaysia, it's a different way of managing it. East Coast, the dependents don't work. So, you can see dependent claims contributing 50% of your overall claims. That also lies the challenge, right? If you start having targeted risk factors intervention within your organization, you can only touch 50% of your claimants. The other 50% stay at home. So again, this has moved to a different level. How do we then start managing this? And obviously, why do these claims? Why is the claims higher? Why do I go to certain hospitals more expensive? Why do certain clinics charge more expensive? If you ask us, we have a list of clinics, list of hospitals, and list of physicians' claims, fees. We know. An insurance company also know. And I can tell you, if a client asks us, how do we manage the claims? Pay and file. If you have high hospital claims, very expensive, those days we have this thing called managed care, which I'm going to touch a little bit more of your time. Pay and file the claim. Don't use the cashless facility. You will see your claims coming down. So these are some of the information that is happening at the moment. Companies, insurance companies are digging deeper into information to try to make sense, try to manage it. And from there, they'll take action. They start taking action, what we mentioned, how do they plan design? How do they design the benefit program? For example, oil and gas companies, government-linked companies, the benefits are very rich. They cover you, your dependents, unlimited benefits, right? Oil and gas companies, those days, very rich benefit. We call it cradle to grave benefit because it covers you from the cradle all the way to the grave. Literally, not kidding. So the question is, with the rising healthcare costs like this, how can they start or continue the coverage for you, dependents, and to certain companies, even the parents' medical are covered? How can they afford? There are oil and gas companies that covers medical up to $80 to $100 million ringgit a year. It's very expensive, it's very high. How do they manage it? How do they buy back this unlimited coverage from the employees? Information like this will show them. Actually, we use a lot of analytics to then try to tweak the plan design to manage this better. Another thing is productivity. A lot of organizations are very also driven on this. How do they manage healthcare costs with productivity as well? Staff engagement, increasing staff engagement, increasing productivity, because they view that salary paid to an employee motivates, but they look at benefit costs paid to healthcare. It's just an hygiene factor. I have it, it's good. If I don't have it, it will demotivate, but it doesn't motivate me. But how do I change benefit costs to motivate an employee? Organizations around Malaysia are struggling with this challenge, are improving the benefit to make sure that benefits not only engages, but then start drawing productivity. So what's next after this? What is tomorrow to come? I've got this picture of an elephant because we like to use this as an example. If you blindfold 4 persons in the room and you ask them each to feel the elephant, one on the tusk, one on the trunk, one on the leg, and you ask them what do they feel, the one holding on the tusk will feel is very hard. The one on the tail probably think is very hairy. The one on the leg probably feels very rough. So everyone feels a different part of the elephant, but everyone is touching the elephant. It's something like information as well. Every party touches some part of the information, but they don't get the full picture of it. Next slide. I'm moving a bit fast because I know that I'm conscious of time. Sorry, it's a bit good. So, sorry, next slide. So, yeah. So insurance companies, Now, insurance companies focuses on demographics and claims. These are the 2 information that they have at the moment. They know what is your average age. They know what is the age of the employee. They also know the claims. Next slide. But what most companies don't know or they don't relate is what is the health risk? What is the risk of the employees facing? How many smokers are there? How many of them are sleeping 7 hours a day? How many of them are eating 5 fruits and vegetables? How many of them are walking 10,000 steps a day? How many of them having heart diseases, borderline diabetic? The other thing is more important. How many of them, the behavior? We have organizations that started smoking cessation. The results was 0. They don't get any results. Why? Because people don't even want to quit in the first place. Do they even do a survey and ask employees, are you willing to quit smoking? If they're not willing, whatever goals and whatever carrots that you hang, it won't work. So do we also check on the behavior of the person, of the employees, whether they are willing to make a change and tying all this together? That's like, I think, and also the other things that surrounding this, what is the regulation changes? We saw the last 2 years, amendment of the 13th schedule, which is the physician fees. Then we have GST last year, and TPPA is coming. What are all these having to tell on healthcare costs? How is this going to affect healthcare costs? What is ailing at the nation? What is ailing the global? What is industry? What are the competitors doing? Vendors? All these things also have an impact on the overall data that we are collecting. And the very important thing is that we start making connections to all this, to start making it very meaningful. If you start a healthcare targeted risk factor, prevention from an organization? Do you relate all this information to then start designing this? Do you relate all this information to start running this sort of program? So this is one of those classical examples. If you look at this, this is a GP claim, right? GP is the clinical claims. You notice if you tie a GP claims against absenteeism, wow, on the Monday, high utilization, high absenteeism. Right? Obviously, because a lot of people want an extended weekend, right? So on Monday comes, they just go to a clinic. You know, the easiest way to fake a MC, don't quote me, is diarrhea, right? Oh, I'm having a diarrhea. Doctors can't check whether you're really having a diarrhea. So when we see a lot of high diarrhea claims on Monday, likely. So these are things where we see in information as well. Then do we relate this to health risks? High claimants, if you put high claimants together, are they also smokers? Are their BMI above certain BMI rate? That is where you start correlating information and start making sense. When you have all this information, then you move down to do a plan design and your risk-targeted risk intervention become more effective to a certain extent. So the thing is in the insurance and the industry is we have a lot of information here. Why? Because when someone makes a claim, we know who they are. We know the top 10 claimants. We know all the claimants in the organization. We know who they are. Right? But the thing is, we notice that 70% of the medical costs is from about 30% of the population. Bulk of the population, only 70 of the population only contribute 30% of the cost. For example, if an organization insure a program, very likely the top 30 claimants will form 70% of the premium cost. Meaning, you're only insuring for 30% of your population. The other 70% of the population are not claiming. They are not. So, rightly speaking, what can you do as an organization on this? If a person is chronically ill, what can you do? You can't stop their long-term medication, they get worse. So you just have to continue with the care. Right? But the million-dollar question is, who are the people here? Those at risk. Those you and I do not know. Because as we mentioned this morning to now, how do we integrate data? How do we know health risk assessment of a particular employee? Those who are borderline diabetic, those who are borderline hypertension, how do you know who they are? They are all sitting here and they don't claim. So we don't know them, right? But how do we then target this employee as risk and move them back into the government? We get a lot of questionnaires by the employees to get more deeper into who are your employees, the population that you're trying to manage, because there are very different sets of information that you have in there. But we need to start moving. I want to end with this because, as I mentioned, this is very commercial driven, it's very business driven. We do a survey. I think this survey was done last, I think it was 2 years ago. We marked down 80 of our top clients, those who did nothing to their benefit, and those who did something to it. And those who don't do anything to it saw a 70% increase in the healthcare costs versus those who did something. So we call this the cost of not doing anything. Why? That's what we have spoken this whole morning. Malaysia is getting sicker. Ministry of Health shared some data as well. I think I just saw the Malaysian survey, 17% of the population were diabetic in 2015 survey, versus in 4 years ago it was only 14%. It was very big increase in terms of our conditions. We are the fattest nation in Southeast Asia. So chronically, the health system, the health of the nation is not doing well. Plus, we've got a lot of this increasing in terms of medical costs. So which is why a lot of organizations are struggling. How do we then make the medical costs increase in less people than this, and we need to start looking at something. And obviously, looking into data analytics helps us in managing this. Right. Thank you very much for your time.
Thanks again for staying back. We are having Mr. Simon Thomas, is a partner and vice president of IBM, and who knows natural language that we do not know. I only know 3 languages. And he is a business analytics leader, as well as subject matter expert and thought leader, and who has built and grown up and lead the multiple independent consulting practices for IBM. This includes strategy and analytics for IBM Asia Pacific, business analytics for the IBM Service Integration Hub, as well as business analytics and optimization for IBM Global Delivery Centers. It's all foreign language to me. And when we welcome him with this long series of experience, and certainly you're the expert in this field, to give a talk on big data and healthcare in the cognitive era. Simon, please.
Can everybody hear me?
Yes.
Excellent. Dr. Goh, Dr. Thomas, distinguished guests, and everybody here, thank you so much. I'm really looking forward to this presentation. I think you could keep the lights up, because my midnight deck is black, so that okay, well, maybe bring it down.
Yeah.
All right. Also, I want to make sure I can catch everybody who's sleeping after lunch. So if you're sleeping, I'll be standing next to you, right as I'm speaking. So just watch out for that. All right. So I run analytics for IBM for Asia Pacific. I'm on a consulting business. And what I'm going to talk to you today, you've heard about big data all morning. So we'll touch on big data. And
we generate an enormous amount of health-related.
That was premature. But so we'll talk a little bit about big data and analytics. You'll see that. But what I'm actually going to try to introduce you to is this notion of cognitive computing, right? And cognitive computing is seen as the next era, taking us beyond big data and really kind of bringing in the power of computing in our current generation, right? Into what we can do with data, right? To kick things off, I'm going to play you a quick video just to set the context.
We generate an enormous amount of health-related data, from our personal fitness trackers and mobile apps, to electronic medical records, to genomic and clinical research. Unfortunately, much of this data is discarded or underutilized, and those with least access to the data are patients. What if health professionals could harness the expertise of the best doctors to reach the most remote regions? Or if they could match more patients to life-saving clinical trials? Or researchers could draw insights from massive bodies of data to help them develop better drugs? The good news is that this is happening today with the help of IBM Watson.
All right, so IBM Watson is a cognitive system, and you'll hear me talk about it as we go through. But before that, if you look at the medical profession, I think Dr. Andrew, Dr. Morris, Professor Morris mentioned it this morning. I mean, it's seen as a laggard in the adoption of technology, right? And I think, look, if I ask all of you here who are in the medical profession how much a computer plays a role in what you do day to day, I think. Oh, sorry. I think I know the answer, right? I mean, it's probably not going to be. I went quite far. Most of you would probably admit that computers and technology are more and more being used in medicine and healthcare, but not quite to the extent that you would see it in other industries like telco or banking or even retail and other areas, right? And so you see that, look, there's a lot of improvement that can be made, right? With the better use of computer technology and, helping with treatments, diagnosis, that sort of thing. I mean, there's a chance to really improve patients' conditions and prospects, right? If you look at, the way we conduct medicine, evidence-based, medical kind of diagnosis, it's very tiny. I mean, 50% is the number you see here, but I would suggest that in some areas it's even lower, and we've seen that particularly in developing countries and such. And finally, I mean, with the population dynamics changing, with the aging population really, becoming a factor, right? The need for a next generation kind of next scale ability to handle healthcare is just becoming absolutely essential, right? If you don't change the way we handle healthcare today, we are not going to be able to cope with what's the changes in the demographic that are coming up. I've got a number there for Malaysia. I mean, Malaysia is officially categorized as an aging country now, right? And as you can see that 9.8% by 2020 will be over the age of 65, I think is what the definition is there. So it's a real problem, and we've got to change a lot of things to kind of deal with it. If you look at the money that's being spent on in healthcare, again, huge, right? If you look at Malaysia, this is, I heard 7% earlier,
No,
but
it's wrong.
yeah.
I wish to have 7%.
Yeah, exactly. I think it's a little bit lower, 4.3% according to a study by Deloitte that was done a couple of years back, and then projected to be 23 billion, right? So it's not it's a big chunk of money, right? And there's a lot of opportunity to create efficiency so that you don't necessarily want to spend less money on healthcare, but you want to get your average dollar to take you much further, right? You want to spend, a good money and get much better quality of service and results, right? So you look at that, and in the U.S. it's absolutely crazy, right? It's almost to the point where it's out of control. And anybody watching any of the U.S. Electoral kind of drama that's going on, today, you'll see that healthcare is always in the middle of the discussion. And if you looked at this morning, Professor Morris brought up the twins. If you saw that, right? I mean, one of the factors that affected the difference between those two pictures are the environmental factors, the factors outside of one's own physiology, right? And you can see that exogenous data is a huge contributor to the overall health picture of an average patient, right? And then if you look at the genomics data more and more kind of coming into the picture, but today probably accessed at a very, very minute level, right? But we have the power and the capability to really, do much more today. And then finally, the clinical data, which is actually the least, the smallest amount of data, and some would say probably the least interesting of the data, right? Because the exogenous data, the behavioral, kind of the environmental, what we do to our bodies, right? I mean, we all know we don't take care of our bodies as much as we should, play a huge factor, right, in where we end up. And if you look at 2.5 gigabytes of new data is being generated every day, and you heard this term this morning all over the place, and I'm going to shed some light on it, and almost 80% of it is unstructured, right? I think there was a great definition of unstructured earlier, and I'll go into it a little bit more. And with a technology like Watson, we're creating the capability to start to leverage this unstructured data, and you also heard natural language processing, so we'll talk a little bit about that in a much more effective way, right? So there's a shift that I want to kind of highlight to you for those of you who are maybe not in the IT or technology industry. We started way back in the 1900s, even in the early 1900s, with very simple tabulating systems, right? Computers that you use punch cards, or even before that, just valves, that did a calculation for you, right? We moved in the 50s to programmable systems, right? When I say programmable systems, it's like it's a computer that you can teach how to do one thing, right? And it'll do that over and over again, right? So you can create a claims processing, system on a computer, and you can create, as many claims as you want. So it just repeats what it does. So programmable systems. For programmable systems, if you want to change the behavior of the system, you have to reprogram the system, right? So it's a very big task. Now we're getting into an era called the cognitive era, right? Cognitive for
cognition, right, which is the process of learning, right? And we're talking here about computers that can learn, right? That don't need to be programmed to be able to do different things, but can actually learn from the data that they're exposed to and provide different results, right? And there are three critical elements to making a system or a computer cognitive. One is the ability to deal with unstructured data. The second is the ability to handle natural language. What is natural language? It's basically the ability for a computer to understand what I'm saying right now, right? Or a computer to understand a piece of document that you just kind of feed into it with writing on it, right? It's the ability to handle human interaction in a natural form, very simple. And finally, machine learning. This is the cognitive part of a cognitive system. It's the ability for the computer or the program or the solution to sort of learn from the information that it's been given, right? So we've heard of AI, right? In maybe sometime in the past. This is sort of AI now coming into play from a purely data point of view. Okay? So we'll go into a little bit of a cognitive 101. I figured I'm in a college campus. I couldn't resist a little bit of classroom kind of a metaphor, right? So cognitive 101, very quickly, for all of you folks here who are not IT professionals, just to give you a sense of what we're talking about when we look at cognitive computing, right? So what is unstructured data? This is what a traditional computer can deal with, right? Very simple, right? You've got last name, sales, country, order. It's well defined, right? The computer knows that if it looks down column A, it's going to find the last name. If it looks down column B, it's going to find the sales. Very much what computers can deal with, right? And then now you can go in and say, okay, hey, what was the sales in Q3? And it'll go and find all the sales that were done in Q3, give you an answer, right? What is unstructured data? And what do humans read, right? It's a document, right? Any old piece of paper with words on it, right? A computer cannot understand that because it does not have, a traditional computer cannot understand a piece of document or a letter or a note because it doesn't have the context and it doesn't have the roadmap to figure out what are the parts of that document that it needs to make sense of, right? A cognitive system reads both of these types of data. So imagine in the medical and healthcare industry, right? All of those research documents that are out there, millions and millions of research documents that have been done, all the papers that are written, right? All the publications. I mean, it's humanly impossible for any physician, right, to keep up with all of that. So the ability for a system to comprehend and make sense of unstructured data is extremely valuable going forward, right? So unstructured data. Next, what is natural language processing, right? A computer traditionally, takes input in the form of either a punch card or something that has structured input, in it, or a keyboard, right? Or some computers these days will also take like a voice command, or you can re-dictate into a computer, that sort of thing, right? So very rudimentary inputs. Humans like to talk to each other, right? We just like to kind of speak in English or Malay or whatever it is, and we understand each other. Well, cognitive systems, again, can accept both. They can accept structured data, right, from a database or from a spreadsheet, but they can also accept natural language from a human operator, okay? So that's natural language processing. And finally, what is machine learning, right? A traditional computer doesn't learn. A traditional computer can make relationships, right? So if you have a bunch of data that sort of follows a certain pattern, you can interrogate the computer on the pattern, and you can kind of do some things with the information that you have on hand. But a cognitive computer, much like humans, actually learns, right? So as it gets more information, and as it kind of processes information, and as it sees the results of the information, right? I'll talk about that in a demo that we're, in another video that I'll show you. It starts to change its behavior. So if it sees that every time it suggests a particular prescription to a doctor, the doctor says, no, I don't want that. Next time it comes up and says, no, I don't want that. The computer says, oh, you know what? This guy doesn't like this prescription, even though it's one of the top the prescriptions for this particular disease. He keeps picking the second one. All right, let's go with the second one, right? So it starts to learn, and also it starts to make relationships with why that first option was not picked, right? And starts to look for that correlation in the next time, right? So if he sees that same correlation, he says, aha, he's obviously not going to pick this one, let me give him this other option, right? So it learns from the interaction, it learns from the data that it's given. So cognitive systems learn and grow, right? So I want to test, again, college metaphor, right? I'm going to test our knowledge here, right? So everybody's got a lot of people have an iPhone, right? So let me ask you, is Apple Siri a cognitive system? Kind of, right? It can understand language, right? But it doesn't learn in a true sense. It knows from your behavior, kind of what you tend to like or what you, but it's not actually learning, beyond that point. It's doing referential kind of, understanding, right? Is Google search cognitive? I mean, you can go and type in a natural language. You can just say, what is the best restaurant in PJ, right? And Google search will understand restaurant, PJ, best, and it does a search and comes up with a rating kind of system, or comes up with a food guide or something like that. It knows. But is it cognitive, right? So if you type that sentence in and then follow up with a next, and it gave you a list, and then you type out next sentence saying, leave the first sentence out, right? Put in the next sentence saying, with Korean food, right? You'll get a completely different set of results, because it doesn't know that your first request was for the best restaurant in PJ. All it knows is now you've asked for Korean food, right? So it'll give you a Korean restaurant in Johor, right? Which is of absolutely no value, to you, right? So it's very close, right? And Google continues to astound us. I mean, they've recently done an amazing thing, truly in the area of cognitive. They've had a game playing machine that had won the game of Go, Korean game. So it's getting there, right? But in its simple sense, Google search is not cognitive. And finally, is Amazon.com cognitive, right? Anybody who shops on Amazon knows that if you keep buying something, it's pretty smart. It can figure out that, hey, you like electronics, and you like certain brands and whatever, and it starts to say, hey, how about this, right? It's pretty smart, but is it cognitive? Not really. So all of these systems exhibit aspects, right, of cognitive systems, but are they truly cognitive in nature? Not really. We're getting to those, systems, right? So Watson, in fact, is a cognitive system in the fact that it's able to do all of those things we just talked about in various contexts, right? And the medical industry was the first industry that this cognitive computing was applied to around the area of oncology in the United States, right? So if you look at the ecosystem, that even in a short period of time, we're talking about between 2009, 2010, in fact 2011 and now, we have generated an entire ecosystem of organizations, companies, firms all over the world that are starting to adopt this cognitive capability and build on top of the Watson Foundation, right? So you'll see many brands there that you recognize, you'll even see, in fact, many brands that you don't recognize, but keep an eye on them, because they're the ones that are causing the disruptions, right? And they're the ones that are creating the leading edge, all around the world. And particularly today, mostly in the United States, but very much expanding, outside very quickly. The various kind of opportunities, options that are available, using some examples of where cognitive, cognitive systems can be used. Engagement advisors, right? helping a human, kind of be a better advisor. Look at, discovery advisor, genomics, oncology. I'll do a demo on oncology. EMRs. I mean, imagine the ability for a computer to fully comprehend an EMR, including the unstructured data that's in an EMR, and provide a physician with a truly comprehensive summary of a patient's history, right? Very, very powerful. Some of the organizations that are currently very, very active in applying, cognitive, computing in their business. Mayo Clinic, you see them, the Anderson, and a lot of big hospitals, mostly in the U.S. You will see one kind of stand out. Bumrungrad Hospital in Thailand. They have just last year started on a process of applying cognitive solutions to one of the areas of their practice over there. So it is starting to come into this region, and it's starting to happen. Now, the first example of cognitive technology and Watson being applied in medicine was around oncology, around cancer, right? Obviously, a very, very big issue in the United States, and so and an example of an area that has a heavy reliance on historical, results. The immense amount of research that's going on. I mean, it's impossible for an oncologist to keep up with everything that's happening in oncology, in research around oncology, all around the world. You need something that can go through all of that information and net out what is meaningful to you and to the patient, right? And that's what the system does. And we'll look at a quick.
Cancer is the second leading cause of death in the U.S., and in the next decade, demand for treatments is expected to grow by 42%, creating a shortage of 1,500 oncologists. Meanwhile, medical information is doubling every 3 years, making it more difficult to keep up with the latest treatment options. Memorial Sloan Kettering has been training IBM Watson to help close the gap, as this live system example illustrates. Let's say I'm a clinical oncologist preparing to see a patient. I step into my office, and instead of spending my limited time digging for relevant information, I select my patient from the queue and use Watson to summarize the relevant facts from the electronic health record and identify areas where more information may be helpful. Next, I can match the patient to a clinical trial, or review the suggested treatment plans Watson has presented. Green means higher confidence, while red means lower. To make recommendations, Watson has extracted knowledge from guidelines, best practices, 12 million pages of journal articles,
12 million
medical textbooks. Watson provides a visual timeline of the treatment plan, as well as the plan's suggested modalities. Again, they're color-coded by confidence level. Each of the blue icons represents an opportunity to dig deeper into evidence. For example, I can review the specific sources behind each component of Watson's recommendation. Watson has also suggested additional publications for my consideration, an overview of the protocols for administering the treatment, and a summary of information of the suggested drugs. When I'm ready, I can select the treatment information to add to the patient's medical record and share with the patient.
So, very simple example, very quickly. This is an actual application that's used by Memorial Sloan Kettering, in their oncology area. And if you can see a couple of principles there, right? Watson is not a doctor, all right? It is not going to recommend a diagnosis, right? It is going to provide options to a physician, right? Who can then look at that data and determine what is the best course of action to be taken. Now, if you saw it, whenever it comes up with a hypothesis, when Watson thinks this is the best treatment, the doctor can go in and look at all of the evidences that Watson has applied to come to that conclusion. So he can look at, he can maybe go through and say, oh wow, this is based on that research paper from Dana-Farber Cancer Institute, and I know those guys are full of crap. Forget that, right? That sort of thing. So it's not a conclusive, it's not trying to give a conclusive diagnosis. It's trying to help the physician, right, come to the right answer, right? And it provides the evidences. 12 million documents, right? Try having a doctor go through 12 million documents before they visit, they meet with the patient. Impossible, right? And so it really takes out the, increasing the odds, takes out the guesswork, right, from what is being prescribed to patients. So the real example being used today in the United States. Another example is around EMRs. Again, EMRs on their own, just forget cognitive and forget natural language processing. Just pure data EMRs are rich for big data and for analytics and a lot of data mining and that sort of thing. But when you apply cognitive and apply natural language processing, machine learning to EMRs, you now get a whole new level of advice to the physician on a patient's history and on patient's records. Clinical trial matching, right? So very big in cancer, right? Because look, the treatment that you want for your loved one who's got cancer is more than likely going to be in the process of being tested or being in some kind of trial, right? And so, the ability to find a trial that best matches with your patient, your loved one's, a particular condition is extremely important, right? So with the ability to handle, millions and millions of documents and tons of data, a system like Watson or a cognitive system can find that match much, much more quickly than a physician trying to kind of work through his network or through kind of just raw data. This is some of the more newer stuff. In general, if you give Watson a bunch of data, right, that looks like a universe of stars, the first thing and the most important thing that it can do is convert that to contextual, meaningful data, right? So it turns that data into what you are interested in, your context, right? It understands what's meaningful to whatever you're looking for, right? And it has learned from your behavior and from your interactions in the past, so you are getting a result that is very, very tailored to what you need to get your job done, right? And a very new area now, and one that's getting more and more, is applying visual analytics. So the ability for a computer to analyze an image, right, which is incredibly complex. I mean, if you think of what our eyes and our brain do when we look at a photograph, I mean, it is unbelievable, right? And you try to put that into a computer, and you just kind of started to get to the holy grail, right? And so the combination now of imaging analytics, right, and cognitive and natural language processing, machine learning is now giving you the ability for radiologists, for example, to be able to look at multiple historical X-rays or results from CT scans or whatever, and use the system to spot trends that are too delicate for a human eye to catch, right? And so we're starting to see the results of this. This is very much in its infancy, and the results that we can expect from this in the next short term, right, is going to be really, really remarkable, right? And all of this is happening in real time, right? Now, this is what the industry is sort of talking about, right? You look at these are doctors that are talking about how cognitive computing is being used today, right? Watson is the tip of the spear. The learning engine, and its capabilities, the opportunity for Watson to impact outcomes. And then finally, from the pundits out there, they're starting to also recognize that the power of cognitive computing really has the ability to change the way that we apply computing to our normal lives, right? Starting with medicine, but going into many, many different areas, right? So to wrap up, and I was telling Professor Thomas that I prepared a 1-hour lecture, and had to kind of squeeze it into 30 minutes. So I'll leave a few minutes for questions after this. But to wrap up really quick, my intention was to kind of give you a general understanding, right, of cognitive computing, right? Just so you folks are now part of probably the 0.0005% of the human population that know what cognitive computing is, roughly. how cognitive computing is being used in healthcare, right, and how it's actually helping healthcare in a big way. Examples of the applications. So I showed you the oncology example. I had an EMR example that I was hoping to show you as well, very powerful, and an imaging example, but we can, we can do that at a different time. But just give you an idea of how it's being used today, right now, in this field, right? It's not theoretical, it is real. Who's using cognitive in healthcare? So you saw all of those hospitals and all of those centers, and one even close to us here in Bangkok that have started to use cognitive computing in practice, right? And then what are the analysts and industry experts and physicians themselves saying about the impact of cognitive computing to healthcare, right? And I think once you look at all of that and kind of look at what cognitive computing has in store, and all of you folks here, I presume, are somehow related to the healthcare field, either physicians or in the healthcare administration or something like that. I mean, there's really only one question that's left, right? When will you start using cognitive computing in healthcare that you are working with? Right? That is just the only thing. I mean, it's here, it's happening. It's a question of adoption, and it's a question of transformation, right? So that's all I had, and I've got maybe a couple of minutes for questions, or we'll take questions a little bit later. Thank you very much.
But nevertheless, it's from Prof. Morris, who is a professor of medicine and director of the National Institute of Population Health Science and Informatics. For those who have just joined us in the afternoon session, he has given us the first talk, and the second talk will focus on establishing a nationwide health research infrastructure. And
thank you. Thanks for hanging around for this last session. It's 5 o'clock in the morning. So I recognize that one of the sponsors is Dr. Koh's team at the Clinical Research Centre. So I thought what I'd do is talk about my other job. So for 2 days a week I work for the government, and I say that 2 days is quite sufficient actually. So one of my responsibilities is Chief Scientist for Health in Scotland. So I'm responsible for health research, policy and funding for Scotland. So what I thought I would do is talk about how can we gear up the health science research capability in Scotland and compare and contrast what you're doing in Malaysia. So that's what I'm going to do. Is this going to work? I'm doomed today. So I was very impressed with your CRC as the one-stop centre to meet all your clinical research needs in Malaysia. I love that. It's a great strap line. So I'm going to steal it and take it home. But I'm going to argue that we need to put research in context. Sometimes I struggle to win the argument that research is core business for any health system. That is the key message. How will we adopt and embrace new technologies, as we just heard, or new medicines, unless we evaluate them and demonstrate the return on investment? What I'm going to suggest is that if we're going to embed research within a health system, then we need a robust strategy, and that there are 6 guiding principles. I'd be interested to see if you subscribe to those guiding principles. And what we're trying to do is, as a young man, I'm trying to say, what will Scotland be famous for in 10, 20, 40 years' time? What are going to be our major industries? Because it won't be whiskey. I was dismayed to learn that we came second in the World Whiskey Tasting Championships to Japan. So it won't be whiskey. We used to have oil, but now the price of oil, and I think Malaysia's probably suffering from that, because off Sarawak and Sabah, that's all the oil is in. So what we're trying to do is say, why isn't Scotland famous for health science, transformation and economic growth? And I'd be interested to see if Malaysia has that same vision. So, and just to emphasize, we have a very rich health science heritage. So this was a guy, Alexander Wood, about 140 years ago. He invented the hypodermic syringe, first used in Great Britain, so that was the first one. What about this one? It doesn't show, it looks much better on that screen, doesn't it? everyone should turn around. So obstetric ultrasound transformed the care of obstetrics and gynecology, invented in Glasgow by Ian Donald. What about this one? Laparoscopic surgery. You know, in my day, you used to have laparotomy scars this big, the size of a crescent for a cholecystectomy. Those days are gone. So that was revolutionised. This is Sir Alfred Cusheri, so he was a Scot. I always look at this slide and I say, this explains why you can never find a surgeon in a hospital, because they're all there. So, so that was, what about another one? MRI. So we did the original work on MRI, commercialised by the Japanese, the Germans and the Americans. There's a message for you. And lastly, of course, Sir Alexander Fleming, penicillin. Penicillin cures gonorrhea in 4 hours. So, but he won the Nobel Prize for discovery. So there's great heritage there. So our aim and our vision is to get that heritage back. And lastly, let's see if we can do this. Yeah, radiology. We talked about imaging. Can you click on that? Because this is the original, first ever radiological image. There we go. That goes back to 1898. That is actually a frog. Who knew that was a frog? And then, you see, he moved on. This is John McIntyre. So that was the first video image of a human heart. Yeah. So, well, this is an interesting one. This is after nasi goreng. You see, there's the stomach empty. So John McIntyre founded the first radiology part. So there's great, I'm sure if you went through Malaysian history, there would be similar little anecdotes. And there is I'm delighted industry are here today, because this is also about economic growth. So this slide, it must be true because it's the Bank of England. It shows you productivity in the UK. And even I can see, oh dear, it's fallen off. Okay, so productivity is falling. I think you emphasised that. So how do you increase productivity? It's about innovation. How do you innovate? So our challenge is to actually drive innovation in health science. So I talked about this morning. So we're trying to innovate as a nation, and I sense, Dr. Ko, you're trying to do the same. Let's do this on a national scale. And there is a case for change. We've rehearsed this today. The changing population profile, the pattern of illness, the accumulated burden of long-term conditions, unacceptable health inequalities. You know, how do we assess technology in the development of medicines to make sure they do bring benefits? I do think in healthcare there's been a tendency to allow technology creep, and it's really important that we evaluate and demonstrate value and return on investment. So I think for cognitive computing, we've got to demonstrate that value in a sense. And the opportunity to reduce failure demand. And this is when you have a delay in presentation, a failure of early diagnosis, and you actually choke up the system downstream. So that's what we're trying to do. And to do this, I quite like this phrase. The future is 4P medicine. It's not my phrase. Leroy Hood coined it. That's predictive, preemptive, personalised and participatory. and it will be enabled by many of the things we've heard about today: genomics, deep phenotyping, informatics, analytics, and this new social contract, so that people are empowered to look after their own health. So the wider context, so I spend, I don't know what your budget is, I get £67 million a year for health research. You're shaking your head. So that's about 300 million is what I get. And that's on a total budget of 12 billion. But the underlying principle is to see the health system as an asset rather than a liability. If we get alignment right, there's no reason why we can't drive a strong, sustainable economy through the healthcare system. This is alien to some people. People just see it as soaking up, as you quite rightly said, soaking up resource. But this is a huge global market. We heard about cognitive computing, and we estimate that the healthcare market internationally is about a $1.8 trillion US dollar global market, and it's growing at about 5% per annum. So if you have good products within that market, you can drive economic growth. And at the moment, this is our, as you can see, this is the whiskey. It's about 5 billion GVA. But we're not bad in technology and life sciences, and we want to try and double that. So, what are the main industries in Malaysia? Is it still oil and gas, yeah? See, these are the sorts of data our politicians will look at, because they want to enhance the so-called global value add. So it's useful to have these types of data so that you can reflect on that. There we go. So I've shown this slide, and this morning I talked about this end of the equation. Now I'm going to talk about how do we use, what's an ecosystem that drives research, development, and innovation within healthcare. Because this should be core business for a health system. So every person or patient that I see in my clinic, we should be thinking, how might they contribute to research and innovation so that it enhances the treatments of folk tomorrow. So this is my office, the chief scientist. So it's quite a grand term. I don't feel like a chief, I must say. So the chief scientist's office basically says, what is the policy to drive this in the health system? And what we said, this is a bit busy, but there are 6 things you need to do. And I'll just rehearse those. Firstly, build on the strong academic base. And I think Malaysia, you've got 2 or 3 universities in the world's top 200, so you've got a good economic base. This is around partnership. So seek out and deliver partnerships with a tripartite mission of research, education, and quality of care. Now, research shouldn't be over here, a sort of optional extra, and quality care here. It's about bringing those worlds together. Thirdly, it's about the data piece. So data science, the theme of today's meeting, should be at the heart of everything we do, from health, social care, and non-health sources to drive better treatment, safety, and research. Fourthly, it's the red tape. Do you have red tape and bureaucracy in Malaysia? No? Because we need to ensure the regulation and governance is proportionate and fits the purpose. Fifthly, it's about working with industry in a transparent way. Pharmaceutical, informatics, medical devices industry. And lastly, we're trying to present Scotland as a single research site, which I think you're trying to do in Malaysia. So these are our 6 principles. I just want to rehearse them now. So what about our strong academic base? So we've put a lot of money into research infrastructure. And I was scanning your website, Dr. Coe, and you've got beautiful pictures of each of your regional research facilities, whether that's in Kuching, even Cebu and Sabah. I think you've got 5 or 6 zones across Malaysia. So this is our equivalent. So this is the Queen. She was opening this new hospital. But wherever you go, we've got infrastructure. And actually, industry hates paying for other people's infrastructure, don't you? They're all nodding vigorously. So there is a responsibility to actually put infrastructure in place. So these are all clinical research centres across the patch. And it's pretty successful. So we're 8% of the population, and we bring in about 12% of the funding. So it's about a £300 million activity. But we could only do that because we put money into the infrastructure. The other part of the infrastructure is capacity building, and we talked about this morning. The lady there asked about, so we put a lot of money into the next generation, because I'm an old guy. So how do we support the next cohort of clinician scientists? So we've got a career track which supports, or partly supports, buys out clinical time to do research. And I think that's very important. The second thing is, in terms of that academic base, how do we give a research infrastructure? So this is the map of Scotland, and it would be the same in Malaysia. We've got all these legal entities all delivering healthcare. We've got 14 health systems, some national boards. So we simplified it and we zoned it, and I sense you've zoned it as well in Malaysia. So west, east, sort of Middle East, although that's not the right phrase, and the north. And they have responsibilities across the track. So it's about being business-like and commercial in how we deliver commercial research. And then, you've seen pictures of these centres already. We create what we call a biomedical backbone. So if you go to any one of these places, you know what type of service you're going to get across the country. So we've called it National Research Scotland. So we've put our clinical research facilities in place, but we've also invested in the data piece, the imaging piece, the project management, the tissue, so that's all the DNA, biorepositories, and the patient engagement. So this nationwide structure does all that stuff in a harmonized way. So it's about collaboration, funding, and defining the function and trying to deliver a streamlined process so that if a company comes or a researcher comes, they know what standards they want. Because industry have 3 metrics. It's very, very simple. Speed, quality, and cost. And it's a global market. So IBM, you can go anywhere in the world. Pfizer can go anywhere in the world. So there's no point in Johor Bahru competing with Kuala Lumpur because the competition's out there. So, and we have that in Scotland. Aberdeen competes with Dundee, and it's nonsensical, because if you can work as a critical mass, then you'll be globally competitive, and that's where you want to be. So we've created these 4 regional hubs, and we've asked each of them to lead on a key function, whether it's about commissions, IT, informatics, contracts, etc. So it's about creating this ecosystem which is coordinated to facilitate clinical research at scale. So this is, I'll flip through this, but you can see how we've tried to reduce the complexity, talk about national delivery and development, national delivery with leaderships, bridging into local delivery founding governments. So it's a systematic business-like approach to clinical research. And then, this is a bit busy, but of course healthcare is complex, so across cancer, diabetes, stroke, pediatrics, primary care, mental health, we have appointed people nationally regardless of if they're in Kuching, they live in Kuching, but they work for the nation. They have delegated authority to lead for the nation across those domains. So you convene a leadership team. And again, they are anchored in each of the 4 nodes. So it's trying to reduce the complexity of health research for a nation. So achievements, so we do about 300 new commercial studies a year. We're about £18 million per annum in terms of commercial activity. We now have best-in-class contracting times. We're down to, well, I'll show you actually. We recruit to target 77%, and we've got lots of industry engagement. So Pfizer, PPD, Quintiles, and Roche have signed up with the nation as a preferred partner. So we're basically trying to offer a service which is fast, efficient, with meaningful feasibility, reduce startup times, and deliver to target. So it'll be the same here. And recruitment is number 1. We want to deliver rapid setup, active study monitoring and planning, and really use our informatics and public engagement to drive up recruitment. So that's really good. So why are we doing this? To enhance the health and wealth of the nation. These are quite good slides, aren't they? So that we deliver consistently and recruit to target and create more patients per study. There's nothing worse than starting up a study site and it doesn't recruit any patients. So that's the sort of clunky stuff. Just to emphasize that we do want to work with industry. So it's a key part of our domain. So in terms of tissue, we've got a single biorepository of tissue service, so you can actually see what tissues where across the nation. And this is what so we recruit to recruit. So we've got a national register, trying to get up to 1 million people to agree to participate in the future in clinical trials. We don't know what the trials are, but they've agreed that we can screen their medical records, then write to them and say, there's a trial on this, would you participate? And it works. There was a researcher who wanted normal individuals to undergo 2 endoscopies. It was ethically approved. Couldn't recruit, and we recruited 25 people in 2 weeks using this register. So it's a way of, so I don't know if that's something. And for disease-specific stuff, we've got dementia, joint dementia research, joint diabetes research. So general population, way of using informatics, and disease-specific. Okay. So that's the second thing. The third thing is this data science, knowledge through data. And as we've heard, this is my mate, this is John Mattison, who's the CIO of Kaiser Permanente in San Diego. We've heard today that healthcare is becoming increasingly intensive. Internet, smartphones, socialome, quantified self, exposome, $1,000 genome, EHR, you know, this is the world that we're living in. I don't know what any of those words mean, as you say. This is the world that we are living in. So I thought I would go back. I graduated, as I said, I was in Sarawak in 1985. I was very well trained by Dr. Chu Peng Hong, and I managed to get my medical degree in 1987. Okay. Let's just consider, since 1987, we've seen remarkable, that's why I showed those pictures at the bottom, remarkable transformations in medical care. The average life expectancy in the UK has gone up by how much since 1987? Have a guess. 40%. I like absolute, not relative. 40% would be quite high. It's gone up 8 years. So since I graduated as a doctor, average life expectancy has increased. It's a remarkable fact, isn't it? It went up about 3 months per year in the 20th century, which is a remarkable fact. But then I thought, what did computer technology look like in 1987? Who here doesn't remember those? Pardon? You've never seen those? That is a floppy disk. That is a floppy. We call them floppies. And this was a big floppy because it held 1.4 megabytes of data. So this is my life. This is when I graduated. Where are we now? So we've gone through gigabytes, which is 1,000 of those things. Okay, and 20 gigabytes will host the complete works of Beethoven. We've gone to terabytes, we've gone through exabytes, we've gone through petabytes, we're now on to zettabytes, okay? So the World Wide Web contains 5 zettabytes of data. So to think where we've gone from in the last, well, since I graduated. And this is pervading other industries, as we said. So Google has about 15 exabytes of data. This is a shopping store, has 5 petabytes. This is the CERN Hadron Collider. Do you know where they're the Higgs boson? This is Peter Higgs, the Higgs boson. You heard of that? He won the Nobel Prize. Really, he found a particle which explains mass. He's a particle physicist. So he's from Edinburgh. He won the Nobel Prize 2 years ago. That collects 30 petabytes of data per year. This is amazing. Do you know what this is? This is the square kilometer array. It's the biggest telescope on the planet. So they fill a square kilometer, staring out into space. That will collect 10 petabytes per hour of data. It's just phenomenal. And what we're doing in healthcare, we're still using paper. And I showed this slide this morning, but I think this has been a great day, because today we've heard about sensors, natural language, cognitive computing through machine learning, data architectures. And there is an opportunity to drag these into healthcare and demonstrate value. So this is it looks better up there. This is the big data tapestry of healthcare. And as we heard, a lot of it is unstructured, whether it's socioeconomic, social network data, genomic data. So this is the tapestry that's coming to hit us hard. And I talked about the FAR, and the question is, do you think that Malaysia, on top of your clinical research network, you could put a data science capability to drive all these efficiencies? So I put these slides in at lunchtime because I'm happy to talk about this governance infrastructure, research infrastructure, and we're talking about safe havens where we actually do the data analysis. So these are trusted research environments where the safe environments work with safe people, so we accredit people, with safe data, we de-identify it, with safe outputs, so that we check there's no disclosure risk. So we've got a lot of work into that. So we have 5 of these across the nation. And as I suggested this morning, we have policy underpinning this in terms of a data vision, data linkage strategy, and a framework which allows us to do this. And actually a service which actually takes people around the loop. So if you want to use the data, you can phone one number, and there's a team which takes you around the loop. And they're looking after about 300 projects to use the data. But again, this notion of providing a service for our researchers. So regulation and governance, because this is really important. There's no point being excellent at clinical research if it takes 3 years to set up a study. So what we've done is streamline feasibility, so we aim to get feedback within 2 weeks, because we want it in days, not years. So we do that in 2 weeks. We also have single review for contract negotiation and budget. So you contract once for the nation. So you get one price. One price for Scotland, so standard setup fee, price list, standard pharmacy fees plus generic review. And that means, actually, we're not best in the world, we're second best in the world. Ukraine apparently is better than us. But these are our contract cycle times, and you can see that it works. And then in terms of contracting time, we're down to about 50 days. R&D approvals now 12 days. This isn't rocket science, it's agreeing to agree and being business-like in the processes. And as I suggested, the numbers of studies is increasing, as is the numbers of patients. So if you do that, I think one has the benefit of having collaboration at scale across the nation. And because of that, it's attracted a lot of money into the system. People come to us and say, we want to partner with you to do research. A lot of charities have done it, a lot of industry's done it, and it raises a lot of money because you offer a very high quality product and service. And as I suggested, Quintiles, which is the second largest clinical research organization in the world, PPD, which is the fourth biggest, Pfizer, Inspiresite and Roche, they all came to us and said, we want to work with you because of the systems and processes that we put in place. And as I suggested, the values increased year on year. And we're attracting a lot of high value studies, so 1 in 4 studies are more than 50,000 ringgit per patient, which is quite a lot of money. Yeah. So. And because of that, we're now demonstrating we can be the top global recruiter, the first global patient, first UK patient, etc. So compete on the global scale. So lastly, positioning Scotland as a single research site. I just thought I'd show you an example. So this is a new technology. It's called computer tomography coronary angiography. Have you heard of that, John? I'm pleased because he's a cardiologist. So this was a new way of looking at coronary arteries. So classically, and this was true, well, it's true internationally, if you present with chest pain, usually they do your troponin and they say, okay, that's negative. We'll put you on a treadmill and then we'll maybe progress to coronary angiography. And then that assess your cardiac risk. So this is a new technology. Basically, it's, instead of doing all that, we send people straight to computed tomography coronary angiography. So instead of doing invasive angiography, where they put a big needle in there, where do you put your needle, Scott? Oh, no, he's very sophisticated, he goes in there. So instead of doing classical angiography with a dye and we say, can we use CT and imaging to actually define, does it change treatment pathways? Because that's what we want to do. So, and it's important. So what we did is we did a study called the Scott study, okay? Or the Scott Heart study, okay? And what we did across 12 centres in Scotland, because we've got the infrastructure, we said we're going to run the same studies with the same protocol across all these centres. And instead of following them up, we used our data science, so we had complete health record data capture, but instead of sending research nurses out, we got electronic. It's a way of running a clinical study using data as your ascertainment and your outcome definition. And it's really, it was published in the Lancet last year. So it's quite, so over these 12 centres, 9,000 prevented through suspected angina due to coronary artery disease. There were 8,700 patients eligible. And actually, 4,600 were recruited. So it's remarkable, almost 50% of eligible patients took part in the study. Very streamlined, okay? And then we randomized them to routine care, with this so-called clinical equipoise, which means we don't know what to do. So routine care, or CT angiography. And this was in the Lancet last year. So what we saw was, this was CHD death and non-fatal myocardial infarction. So this is standard care, and this is CT. So actually it had almost a statistically significant impact on surviving or having a chronic infarct. And likewise, non-CHD death, non-fatal stroke, a benefit. So what we found was it changed the diagnosis in 1 in 4 and changed the management in 1 in 4. So we showed that this new technology deployed into a routine clinical setting actually changed patient pathways in a randomized study, gold standard. We funded, as chief scientist, we funded that study, and it cost £600,000, so about 3 million ringgit. At the same meeting at the American College of Cardiology, the Americans published a very similar study looking at the same technology. It cost them $40 million. And the reason is they don't have that connectivity and routine cases. So it shows you how such a national infrastructure can drive new science, new discovery. And actually it's changed patient management. You know, we use this stuff now. So what we're talking about is a Scotland-wide ecosystem that brings in academia, NHS, industry, and good policy to drive this. Now you might say, you know, sitting in Kota Kinabalu, why do I need to collaborate? I'm very happy with my own local system. But just to emphasize that medicine is changing, okay? We talked about genomics earlier. So this was a paper in Nature last year. And what they did is that they looked at 20 most common cancers, so stuff like bowel cancer, breast cancer, ovarian cancer, lung cancer. And they asked the question, molecularly, how similar are all those cancers? So this was in Nature. Basically what they showed was that molecularly, i.e. the mutations are very, very different. Every cancer is a rare cancer. So only in 13 genes across all those cancers was there a mutation at a greater than 5% prevalence, which demonstrates that, you know, breast cancer is probably 93 different diseases. And this is the tail. So these are common genes, but actually they're very uncommon in cancer because every cancer has a different mutation. So why is that important? So if I wanted, for example, to collect 250 new cases of a cancer each year for a clinical study, because 250 isn't a big study, you can do the maths and say, well, how many patients in a population will I need to accrue 250 new cases? So across breast cancer, if the mutation is a 1 in 5 mutation, which is very common, you need 1.9 million people in your population to accrue 250 cases. If it's 1% frequency, which is more common, it's 38 million. So Scotland wouldn't be big enough. When you come down to ovarian cancer, a horrible cancer, if you have a mutation rate of 1%, which is pretty common, then you would need 287 million people to get 250 new cases. That's why we need to collaborate globally. Because if a relative of mine has ovarian cancer, I want her to have the best treatment. And we'll only know that if we can compare it across similar patients on a global scale. So that's why we're collaborating, as we understand the molecular etiology of disease. So what will this require? Something called team science, because medicine's been about heroic individuals like Fleming. Actually, if you look at the CERN collider, do you know the physics? That is thousands of physicists all contributing. And I think in medicine we've been too heroic. And it's time we looked at team science and how we reward people who collaborate at the interface, compete at the implementation. Because this will only work with collaboration, deep, deep collaboration. And just to show it's not only us, here's Mr. He was in, do you see that? He was in Cuba today. He's gone to Cuba for a few days. So he's driving on precision medicine, putting a lot of money into it. And actually last week he made his second announcement on precision medicine, which is saying this very thing. You need to collaborate to characterize deeply phenotyped populations at scale for precision medicine studies. And I think your clinical research centre network will be vital if we're going to participate in such areas. So I've showed that this morning, that's what we're trying to do. So to summarise, you can produce efficient, coordinated, nationwide systems, but to do this you need to collaborate at scale if you're going to create a powerhouse for clinical research. And this approach attracts a lot of industry interest if you want to work with efficient people. Contract once, and I think to do this you can gear up for the challenge and requirements of precision medicine. So we're asking ourselves, can we gear this up so that in 20 years' time we'll be famous for health science? And I sense that you have the same ambition. Because if we go back to Darwin, what did Darwin tell us? It's not the strongest of the species that survived, nor the most intelligent, but the one most responsive to change. This will require fundamental change. And what did Roosevelt say? That if you believe that you can change, then you're halfway there. So if you can build a cohort of individuals, leaders who get a movement, momentum, with public support, I'm confident you can achieve great things. So I'll finish there, and thank you so much for listening.
Ladies and gentlemen, thank you for staying on for this last session of the day. In case you're wondering, this is actually the last session, yeah? And very important one as well. Why is it important? As we have a convergence of top minds in their respective field in giving us